Morning, sir. Thank you. Good morning, everyone. Today we'll talk about impact of pre-transplant immune checkpoint inhibitors on use on post-transplant outcome in HCC. So the story of transplant started in 1963, but the successful transplant first happened by Thomas Tarzer in 1967. The story of HCC started with Vincenzo Mazzaferro in 1996 when he did a study on just 48 patients and proposed the famous Milan criteria. After that, there have been various modifications in Milan criteria like UCSF, Toronto, up to 7, and we have been pushing the limits ever since. Now, coming to last decade, there is a role of immunotherapy in all the cancers. How come HCC will be spared? So there's a big role of immunotherapy in HCCs, and using HCC immunotherapy in neoadjuvant setting is a new thing in transplant, and we need to see what the results are and how it helps us in achieving transplants. So there is almost 75% 5-year survival in early stages HCC with surgery. So surgery remains the mainstay of treatment for HCCs. But the outcome depends on undetectable micromats. That's why there can be a recurrence rate as high as 70% in resectable HCCs. So the gap of the knowledge is local control is insufficient until unless we deal micrometastasis. So that's why comes the role of immunotherapies. There are different antigens which are targeted like PD-1 inhibitors, PD-L1, CTLA-4, which I'll come to that in some time. Even BCLC, latest BCLC criteria, as you can see, immunotherapy holds a role in adjuvant as well as neoadjuvant setting. So I'll talk about how the adjuvant and neoadjuvant setting have changed in HCCs and how the field of transplant is changing because of the same. So adjuvant setting is like we are giving immunotherapy post-transplant or post-surgery. So trials like IMB BRAVE 050 with atezolizumab plus bevacizumab and STORM trial failed to show any improvement in recurrence-free survival as compared to surveillance. So we could not see any benefit of using immunotherapy in adjuvant setting. What about neoadjuvant setting? So neoadjuvant setting, the hypothesis is antigen release. There is a presence of functioning tumor increase, which functioning tumor which increases antigen release and which enables T cell expansion, and this helps in micrometastasis eradication. So immune checkpoint inhibitors are being used in neoadjuvant setting rather than adjuvant setting. So in this presentation, we'll talk about the promise, what immune checkpoint inhibitors give to us, what's the problem, what's the peril, and is there a variable, and can we use in all the cases? So the immune checkpoint inhibitors in liver transplant act as a double-edged sword. On one side, they do help in successfully downstaging the tumor, bringing the tumor within transplant criteria and transplanting the cases which are otherwise supposed to be unresectable or untransplantable. So tumor regression and downstaging rates are very high. The efficacy is very high in that. But what is the downside of that? There's a risk of fatal allograft rejection. The allograft rejection T cell attack on the transplanted liver is very high. And this is what we're going to talk about today. So first, we'll talk about the promise, what neoadjuvant immunotherapy provides us. So there have been various studies, like one of these Kasab et al. Study from which compares nivolumab monotherapy versus nivolumab plus ipilimumab, which shows 33% major pathological response rate, which is quite high. Although there's a toxicity profile of about 23%, but it shows 33% major pathological response. In similarly, the study of Maron et al. In sepilimumab monotherapy, they have shown tumor necrosis of more than 50% in about 20% cases. So definitely in neoadjuvant setting, immunocheckpoint inhibitors have shown significant pathological response and even complete response. This is a study from Cheng et al., which shows almost 40% complete pathological response with no viable tumor at the transplant, with no zero recurrence rate in patients having complete response. So definitely, it's a good promise of downstaging the tumor and achieving complete response with the use of immunotherapies in HCCs. So what's the peril? What's the problem? So the T cell mediated rejection, because immunotherapies work on T cell mediation, and there's a constant activation of T cell, which leads to almost 30% higher rejection rates. And the independent risk factor of mortality increase with a hazard ratio of about 9.9. So there have been various studies in literature. These are all recent literature, because all the literature with neoadjuvant setting of immunotherapy and transplant is in last 3 years. So as you can see in various studies, rejection rate can be as high as 27 to 30% with as low as 20%, which means almost every one patient out of 4 will have rejection if we use immune checkpoint inhibitors in neoadjuvant setting. But the good thing is more than 60% are rescuable. We can treat them in more than 65% of the patients. So why this happens? The problem is the unleashing of immune system. The same mechanism which helps in tumor clearance act as the same mechanism which helps in rejection. Even though the serum half-life, as you can see in nivolumab and pembrolizumab, is only 27 days, but the rejection rate can happen as high as 85 days. So it's not just about the half-life of that drug. It's about the receptor occupancy on the T cell. How long the drug is on the receptor in the T cell stage. So this is why the problem is, because we think the half-life is 27 days, we do a transplant after 30 days, then patient comes in rejection. That's the problem we face in that. So what's the timeline about? So there is a critical variable or a washout timeline. Less than 4 weeks after immunotherapy, it's a strict no-go, very high risk zone. Rejection rate can be as high as 71%, as mentioned in the study by Go et al. As we go down to 42 days, again, rejection rate drops significantly. And 6 weeks is the time where there's a statistical tipping in which rejection rate significantly drops. But ideally, the safest zone is wait till 90 days or 3 months, in which rejection rate drops as low as 20%. Because if you can see in this study, if the washout period was less than 28 days, the rejection-free survival was similar to if you have not waited at all. But if it exceeds more than 42 days, you can see the survival improves. So it's not just about the time. The timeline, as I said, is important because 85 days is the receptor occupancy basis. So we wait generally 3 months before we go ahead with a transplant. But it's not just the time, it's the agent which that matters as well. When we compare PD-1 inhibitors with PD-L1 inhibitors, nivolumab, pembrolizumab versus atezolizumab, as you can see, atezolizumab have low rejection rates as compared to nivolumab and pembrolizumab. This is a study from Xu et al. From China, which showed 96 patients. We suggested using atezolizumab as a safer bridge to transplant rather than nivolumab. The rejection rates are significantly lower with a p-value of 0.021. So it's the timing as well as the agent. And is there a benefit in transplant? This is what we are coming at. Why we are doing all this exercise? Is there a benefit in transplant? As you can see, in patients who have microvascular invasion, the survival improves significantly. There is a significant survival advantage in the patient who have microvascular invasion. But the same does not hold true in all the cases, as well as the patients who do not have micrometastasis, microvascular invasion, do not have same benefit score. So what about how what do we do it if we get a rejection? So we have to characterize and manage it. We have to identify the threat early. Generally, this kind of rejection happens almost 10 to 12 days post transplant. We have to check for the biomarkers like positive IPDL1 expression in donor graft, low CD4 CD8 count, and generally the rejection is about grade 3 and they are steroid resistant, so we have to sort to other therapies if we are sure of it's a rejection. And immediate biopsy is essential if we are doing a neoadjuvant immune checkpoint inhibitors rather than doing going for the treatment earlier, which we generally do in living donor settings. So if we are suspecting a liver rejection, we go for biopsy. First stay of therapy is against corticosteroids, but we don't do it again. If it fails, then either go for plasma exchange, which removes the or IgG antibodies or ATGs. As I said earlier, about 65 to 80% of the patient such episodes are reversible, and patients can be rescued. So this is the study from hepatology with impact of pre-transplant immune checkpoint inhibitors on post-transplant outcomes. As you can see, the overall 1-year survival has to be shown about 75 to 88%, with recurrence rate of only 9.9%. And the important thing is the recurrence rate in the patients who have complete response is zero. It's almost zero. So definitely patient using immunocheckpoint inhibitors will have higher rejection rate. The mortality risk is higher, but if they respond and we wait significantly, then the complete cure rate is higher and survival is maybe higher. So overall, the immune checkpoint inhibitors are revolutionizing the downstaging, as 40% can achieve complete response. Although there is a significant risk of rejection, but this can be managed with giving enough washout period. And the immune checkpoint inhibitors are not for every cases, mostly in patients with have microvascular invasions. In future, neoadjuvant interventions gonna play a big role. It's not just about the local control, but again, micrometastasis. And with development of dynamic biomarker monitoring, the neoadjuvant immune checkpoint inhibitors are doing more than just shrinking the tumors. They are providing us with the biology of the tumor, and they will be used in tracking the molecular relapse as well. And definitely they will rewrite the history of HCCs in transplant. So washout period is mandation. Use atezolizumab rather than PD-1 inhibitors like pembrolizumab. Microvascular invasion patients have specific benefit, and early suspicion and early treatment for rejection, if happens, is important. So we have at ILBS operate about 48 patients of HCC for which underwent transplant, among which 2 are one which are very significant, in which we use immune checkpoint inhibitors. This is one of such cases. The patient presented in 2012 with hepatitis C virus cirrhosis. He was given interferon gamma as well as ribavirin. In 2015, the patient developed HCCs, for which RFA was done and sorafenib was started. As you can see, this is the tumor. So after that, patient remained well till 4 years. Then he had a recurrent tumor in segment 6 and 7 with portal vein tumor thrombosis in July 2019. As you can see, the portal vein has, right portal vein has completely gone. These patients. As you can see, the AFP level rose in 2019 from earlier 7 to 798. The patient was started nivolumab therapies, 3 sessions followed by 5-session SBRT, and AFP dropped significantly from 798 to 57. Again, patient remained well, but PIVCA started increasing. The patient was started on lenvatinib. As you can see, the PIVCA went till 1750. Came down to 500 when we started lenvatinib. Again, patient started having loose stool. Lenvatinib was stopped. He was intolerant to lenvatinib. Sorafenib restarted. In October 20, a new lesion has come in segment 7 and segment 8 of the liver, about 1.6 convergement 4 centimeter. The tumor size, almost similar location. And then in December 2020, he was listed and he received a diseased donor liver transplant. We did a diseased donor liver transplant in February 21. Liver was cirrhotic, as you can see, with a cold ischemia of 8 hours, with a warm ischemia of 32 minutes. The important thing is the gross, if you can see, the incomplete necrosis is seen in all the tumor, with percentage of necrosis is as high as 76%. So to conclude, earlier in adjuvant setting, immune checkpoint inhibitors could not be used, but now from a contraindication, we have shifted to calculated risk score for immune checkpoint inhibitors in new adjuvant setting. We have to strictly adhere to for minimum 42 or ideally 90 days of washout period to safety. And it's not to be used in all the cases, but definitely provide a benefit in high risk cases of like microvascular invasions. Thank you.
Sahil, the challenge remains that if you stop, what is the risk that this patient will have progression? Like say he has AFP of 500 or so, and he has high PIVKA, and he's ready for transplant, but in 3 months' time, when you have stopped ICI, what is the risk that this patient may worsen and becomes non-transplantable? Let's say AFP becomes from 500 to 2000. So is there any data of lost transplant option?
Thank you, sir. Sir, I could not find that. I was just looking at neoadjuvant setting in resection and transplant. I could find data on neoadjuvant setting followed by resection and ICI followed by transplant. But definitely, I'll look into the patients because the number of patients are still in. Even if you see transplant 1994, recent only 4 or 5 papers have come on this, and even the meta-analysis, the patients are 250, 260.
Yeah, there are 2 papers, liver transplant, I think Feb or March. Both of them have addressed this issue. I can't recollect the data. The second question, the second experience is that patients who have adverse event on ICI, for example, he has got immune hepatitis or dermatitis or pneumonitis, they are very likely to go for post-transplant rejection. So one of the additional points besides the washout is those who have developed side effects should preferably not transplanted or should be under closer watch. So what is your thought on that?
I totally agree, sir, because the mechanism of having it rejection and the side effects are similar. The patients who have higher complication rate generally either drop out or we have to be on higher tiptoes to see post transplant to look for rejection. Like in general, if we do a transplant in normal setting, we could do steroid therapy before even confirming a biopsy. But in this case, we should not, and biopsy should be first started with, followed by a higher suspicion of rejection.
Any other comments or suggestions? Also, I think I agree with you that Atizo Beva is a very good combination and quite safe. But same could be true for Stride, also possibly, but it's not too sure. Well, if no more comments, thank you.
Thanks.
Do we have a second presentation? No? There is no second presentation. Oh, we could have had Sahil for a longer period. Anyway, okay. Thank you all.